Hi, my name is Clare Sunderman. I am a junior here at Bowling Green State University, and over December I went to Peru on a service learning trip with a group called MedLife. MedLife stands for Medicine, Education, Development for Low-Income Families Everywhere. I spent 9 days in Cusco, Peru, learning about the culture and the need for healthcare in the region. MedLife partners with low-income communities in Latin America and Africa to improve access to quality healthcare, education, and safe housing. I volunteered at a mobile clinic for a total of 3 days and also helped paint a house and also celebrated Christmas with a community near Cusco, Peru. So before going on this trip, I was planning on just comparing the United States healthcare system to Peru's healthcare system, but after experiencing this trip and seeing Peru's healthcare system for myself, I decided to focus on one of the things I learned on my trip, which is structural violence, which I will get to in the next couple of slides. So before I talk about structural violence, I want to talk about healthcare in the United States versus Peru and kind of give a general overview of what that looks like in the two countries. So for the United States, obviously we have a much larger population compared to Peru because we are a lot bigger, but the life expectancy is only 2 years higher in the United States than Peru, which I found to be pretty interesting. The average health spending per person is about $10,000 per person in the United States and only $333. That's in American dollars compared to soles. And these is the data that I found for 2018 and 2017, and then the two healthcare systems that the United States and Peru both have. I really wanted to dive deeper into the different healthcare systems specifically and what the levels of that look like before going to Peru. But after kind of experiencing what both of those look like, I decided it would be best for me to talk about something else, as both their healthcare systems would take about 15 minutes each to fully be able to discuss, as they are very complicated. So the United States doesn't have a uniform healthcare system. Like we have obviously government-funded healthcare, but mostly people are covered by private health insurance companies. So about 75% of the population is covered by private health insurance. But for Peru, they actually have a decentralized healthcare system. There's 5 levels of it. But the Ministry of Health, it's called MINSA, actually covers about 60% of the population for their health services. And then I tried to look up the number of hospitals and healthcare facilities and clinics in the two countries. Peru, I found a large number for both hospitals and healthcare systems and clinics themselves and private practices, but I actually couldn't find that number for the United States, so I just stuck for the number of hospitals for the entire country. So the number of hospitals in Peru is about 606, and for the United States it's about 6,146. And then this picture as the background was actually a clinic we passed in the town of Sexancala. We didn't get to go in, but we learned a bit about it and that they were actually expanding this clinic. So yeah. So to be able to fully understand how things are run in Peru, you need a little bit of historical context. So for about 20 years, terrorism actually plagued Peru from 1980 to 2000. An estimated 70,000 people died actually in this internal conflict. 56% of the victims were farmers, as 79% of the attacks occurred in rural settings. So specifically in the city of Cusco, those who were living up in the mountains, kind of on the outer edges of the cities, those who were able to move inward, and this left a lot of people on the outside not being able to move, so it left them more vulnerable to, of course, terrorism, but then this led to a lot of the um, structural violence that I'll go more into. So structural violence refers to a form of violence wherein some social structure or social institution may harm people by preventing them from meeting their basic needs. This term was ascribed by Johann Golta. So I actually first learned this term while on my trip in Peru, but I've had experience with it in the past. I've learned about it in my sociology class, but how they described it in my sociology class, we didn't really have a term for it. But the example they gave was about two children who both go to the same school, live in the same area, but one with parents who went to college and one who didn't go to college. So we learned about how the child whose parent went to college is actually more likely to be able to get into college versus the one whose parent didn't go to college, not because the child whose parents didn't go to college are not as smart or don't have the intellectual abilities to get into college, but more of how the system is set up. So the child whose parents went to college is more likely to get in because the parents have experience with being able to apply to colleges, they know how the system is run, they know how to take out loans, things like that. But a child whose parents didn't go to college may not be able to help that child be able to apply to colleges or know how they need to sign up for different tests they need to take to get in, or even to the extent of being able to help them with homework so their grades might not be as good as ones who did go to college, because they might have that foundation of being able to help their child through different like math problems and things like that. So that was kind of like the structural violence. It's not any one specific fault, because the things in place just of how the structure is set. So on this slide, I have 4 different terms. I'm going to be discussing in the next 2 slides, comparing the healthcare system in Peru to the healthcare system in the U.S. and how structural violence plays a part in specifically these 4 aspects. So language, so it's how the language a person speaks affects the quality of healthcare they receive. Economics, the socioeconomic status of a person and how that affects the level of care they can obtain. Gender, how one's gender affects their ability to get adequate health care. And geography, how one's location, for example, in an urban setting, rural setting, or in between, affects the ability to receive health care. So that's kind of how I'm defining these terms and how I will be discussing these different topics and how these 4 categories were the main culprits of structural violence in healthcare. So while in Peru, I saw a lot about structural violence and how that plays a part in specifically healthcare when it comes to these 4 categories. So in terms of language, every 1 out of 9 Peruvians speaks Quechua. It's the native language of Peru, but not the official language, as the official language is Spanish. And in rural areas, it's actually every 6 out of 10 people speaks Quechua. So a lot of the people, we learned a lot of the healthcare facilities, they don't have doctors who speak Quechua. They only speak Spanish. So for people who speak Quechua, it's hard for them to go get access to healthcare, as Quechua is not very similar to Spanish at all. They're very different languages. But so most healthcare professionals only speak Spanish. So it's hard to go to the doctor without access to a translator, or even just go to the doctor in general if everything you see, all of the signs are in Spanish, so it's hard to be able to, get access to quality healthcare if you don't speak Spanish. So there's that language barrier. And then in terms of economics, although the government does cover those who cannot afford healthcare, people might be waiting months to see a doctor because they can't access private clinics. Because if everyone, if the government provides a certain clinic someone can go to, if a bunch of people can only go to that clinic's going to be overloaded with people. So we spoke to a man who actually said it took him 60 days to see a doctor for something like common here in the U.S. We'd be able to get in the next day or 2 if you couldn't get in the day of. That's not specifically with like emergency medicine. It would be more like, if you had a weird rash or something that's not exactly urgent, but still something you should get checked out. And then gender, women living in rural areas have limited access to see obstetricians and gynecologists. So almost all of the women we saw and some of the younger girls all had UTIs. They all had problems, and that's because they had never seen an obstetrician or a gynecologist. So I actually looked up on Mensa. I can get access to their website. Family planning and maternal health is covered by the government, but not gynecology as I could find. So it's good that if a woman is pregnant, she can go and get the healthcare she needs. But in terms of gynecology, because you could have ovarian cancer and UTIs and things like that, and that's not exactly covered under maternal health, so it would not be covered by the government. So a lot of these women don't get the healthcare they need. And the most recent fact I could find, a lot of this data from Peru is a bit out of date, but in 1996, 53% of women living in rural areas did not receive any prenatal care. So luckily that has changed over the past couple years, but still that's a large number of women. And then geography, most of the hospitals are concentrated in main cities, while outer towns may have one clinic that cannot perform as many treatments as a hospital. So we saw a girl who had third-degree burns all over her face that she had had for 2 years, but it had scarred so badly that it would require surgery to get all the scar tissue removed and kind of heal her face. But because they didn't have access to a hospital where they lived, the clinic that they had in that town didn't have the things it needed to be able to help that little girl. So she had been suffering for 2 years with these scars because she didn't have access to a hospital. Of course, it's a bit pricey if you need to drive to another town to go to a hospital because that requires having a car. Not a lot of people have cars there. They have little like bicycles that cart people around and like motorcycles and stuff, but not everyone has cars in the outer cities. So there's an inequitable geographic distribution of healthcare workers too. So the highest amount of healthcare workers are in Lima, Peru, and coastal areas, and lower in jungle and mountainous areas. So a lot of the people who live in more rural areas don't have a high distribution of healthcare workers. They're all concentrated in more main cities in the coastal areas compared to those in the rural areas. So that kind of leaves people at a disadvantage. So in terms of structural violence in the U.S., even though I'm talking about the same 4 terms, it looks a bit different in the U.S. than it does in Peru. So 22% of the U.S. population does not speak English at home, and only 36% of physicians in the U.S. speak Spanish. So this 22%, of course, doesn't just include Spanish, it includes Russian and Italian and Mandarin and other things, and the 36% only includes Spanish. They gave other statistics for how many speak other languages, like the languages I just mentioned, but I just put the Spanish one in. So it would be hard for some people to be able to go to the doctor without the help of a translator if their healthcare provider doesn't speak Spanish. So that obviously leaves a large language barrier. If they can't get the help of a translator, even if they do, having that middle person not being able to talk to the doctor directly about what you're going through and having that translation barriers, and sometimes there's not words for different things that are being described, so that's kind of a challenge in terms of language. And then economics, so I looked up and it said that 27.5 million people do not have health insurance in the U.S. I believe that was from 2017. So of course it would make it difficult to pay for hospital expenses and may actually avoid going to the doctor at all. I had a friend who I worked with who she's never had health insurance and she's had back issues for years, but because she doesn't have health insurance, she can't go to the doctor and like get surgery done because she has scoliosis because she doesn't have health insurance, and it'd be too expensive for her to be able to pay out of pocket. So she just avoids it altogether, but her condition's been getting worse and worse. And then gender, so diseases that mostly affect women are actually under-researched. So many times it leaves women undiagnosed and forces to see many doctors before getting answers. So with this one, I found that a lot of times the doctors would dismiss the women because women are seen more as being able to be open about their emotions, and men are, supposed to be, the stereotype is that men are supposed to be stoic, and so if they actually go to the doctor, it's more of something's actually wrong, but women are like more pushed to, if something might slightly be wrong, they're more pushed to go to the doctor and get it checked out, versus men, it's more when it's at their worst condition. So women are more likely to be just written off as just having like pains that can't be answered, and it leaves many women undiagnosed. And then in terms of geography, a life expectancy can actually be correlated to where in the country you live. So like places that are more, it also ties with economics. So low socioeconomic communities or inner cities, or even like places like Appalachia, the life expectancy is lower, and that can be correlated to where they live in the country. So I did face a couple challenges with my trip, and I would do a couple things differently with my research if I could redo it. So some of the challenges I faced was I was getting very specific data for the United States and very broad data for Peru. So it was hard for me to find that balance in between of what was specific enough for Peru and broad enough for the United States that I could talk about them and it would be accurate, but also at the same time, a lot of the data I was finding for Peru was either out of date or from like the 1990s, and like I could find, very recent data for the United States, and I would have to find older data for the United States so I'd be able to correlate between the two, because you can't compare current data from 2019 to Peru's 1996 data like that. You just can't do that. So that was one of the challenges. I had, and then I couldn't find data online for much of the information I learned in Peru. So a lot of the things I learned about the women and how a lot of them had UTIs or things like that, that wasn't data I could find online to back that up. It's just things I saw for myself, and it was hard for me to find data, probably because the websites are, Peruvian websites, and that's just not something I can just Google. Like, if I would Google hospitals in Peru, it would bring up Peru, Indiana, so that was kind of frustrating. So, and a lot of the websites are also in Spanish, so luckily Google does translate it for me, but still having that language barrier of me not being able to speak Spanish and finding those websites that I needed was kind of a challenge. And then also another challenge in not being able to speak Spanish. Many of the patients I talked to only spoke Spanish or Quechua, so I was communicating through a translator. So when I would sit and shadow the doctor, they would speak. The doctor sometimes spoke very little English or none at all, so I would be able to listen to the patient speaking in Spanish, but not, being able to understand what was going on unless the translator was there. And there was only one translator for the 2 doctors plus the dentist and the gynecologist. So I wasn't able to really be able to fully immerse myself in that experience because I didn't speak Spanish. So that's something I would have learned or done differently if I could redo this experience, is actually learn Spanish and be able to better communicate with patients. And then do some more research before going to Peru, and to be able to ask questions more about what their healthcare system looks like, specifically that 5 levels. And there's actually like 4 different levels of hospitals, but again, that's not something I could find online, sadly. And then also get access to websites from Peru to get data, because a lot of times it was very just general data on like a statistics.com sort of thing, and I wanted to find more websites that were from Peru instead of, just general statistic websites. So that was kind of a challenge. It's something I would have hoped to do differently if I could do this again. So kind of wrapping it all up, I just want to talk about a call to action and what you can do in your own community. So specifically, changing your perspective on how you see things. So before I went to Peru, I just kind of assumed, the healthcare system was, quote, inferior to ours, specifically because, they maybe are a lower income country, they're more impoverished, they don't have the education, things like that. But it's much more deeper than that, and I wouldn't have known that without knowing about the terrorism that happened in Peru and the structural violence that was occurring in the communities. So being able to take that and put that into my own perspective in the United States, so being able to take the story of the people who could go into who got into college versus didn't. It's not necessarily because, maybe it is because they aren't as smart, but maybe there are other hidden factors to that, and being able to think more critically about the information you're being given, and kind of change your perspective on things and things that are given to you by the media, being able to dive deeper in and learn more about those things. And then kind of course, as I am recording this for you, I'm not standing in front of you giving a presentation like I was hoping to do originally, but how this relates to COVID-19. So in the United States, at least, I know many people have lost their health insurance because it was tied to their jobs. So, no, this isn't necessarily something I can personally fix. It's just something to be aware of and how our systems are set up, in that, maybe we weren't fully prepared to have a pandemic like this, because if people lose their jobs and they lose their health insurance, I know testing is free for COVID-19, but what if they end up getting critically sick and they get better, but then they have $35,000 payments to the hospital that need to be made because they lost their health insurance and they don't have the money anymore. They don't have the income to be able to pay for that. So it's just kind of thinking about these things and being more aware of the world around you and thinking more critically about the things that are in place. So that's all I wanted to really talk about today. If you have any questions, you can email me at clarels@bgsu.edu. Thank you for taking the time to listen to me today and listening about structural violence in healthcare. I really enjoyed my trip to Peru. I learned a ton. I had a lot of fun. It was great meeting people and interacting with people from another culture and another community. So, yeah, and that's all I have time for today. Thank you so much.